Hello, I'm Dr. Ann Bass. I've been treating multiple sclerosis for 29 years, most recently at Lone Star Neurology of San Antonio. I'm talking today with two inspiring individuals living with RMS and being treated with KESIMPTA.
Hi, I'm Jamie-Lynn Sigler. I'm an actor, mom, podcast host, and MS advocate.
I'm Caylee, an MS advocate, college volleyball coach, and a big fan of the outdoors.
We'll get started in a moment, but first, let's review some information about KESIMPTA. KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis in adults, including clinically isolated syndrome, relapsing-remitting disease, and active secondary progressive disease. It is contraindicated in patients with active HBV or history of hypersensitivity to ofatumumab, or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reactions have included anaphylaxis and angioedema. Warnings and precautions include infections, injection-related reactions, and hypersensitivity reaction, reduction in immunoglobulins, and fetal risk. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions. So today, we will be discussing the importance of starting high-efficacy treatment early, specifically diving into KESIMPTA data in recently diagnosed treatment-naive RMS patients.
Before we start, I just have to say this topic is so important to me. I have been living with RMS for over 20 years. I was actually diagnosed back when I was on a certain TV series in the early 2000s. Back then, high-efficacy treatments like we have today weren't an option. I started KESIMPTA in 2023, and I so wish it had been approved sooner.
I was so overwhelmed when I was diagnosed during my final year of college. I was supposed to have a great senior year and volleyball season, but suddenly I couldn't pass, set, or hit. So I went to my doctor. Anyway, there were so many treatment options to consider. My neurologist recommended KESIMPTA first line. We talked about it and it sounded right to me.
Whether patients are treatment naive or have been on a disease-modifying therapy, there's a lot that goes into treatment decisions.
Dr. Bass, what do you consider before recommending a particular treatment for patients who have never been on therapy before?
There are so many factors, and I evaluate each decision on a case-by-case basis. Overall, things I consider are presentation of symptoms, relapse history, and lifestyle. I also take into account the safety and efficacy profiles of the treatments. I consider KESIMPTA with its powerful efficacy and its proven safety profile. And with 1 minute a month self-administration, I don't have to deprioritize the patient's lifestyle. For many of my patients, it's the right dose, just 0.4 milliliters per injections, the right frequency, and the right route of administration. I believe in starting high-efficacy treatment as early as possible, and there's growing evidence about the importance of doing so.
Is that one of the reasons you prescribe KESIMPTA for patients like me who have never taken an RMS treatment before?
Exactly. I'll briefly mention some data from the phase 3 pivotal studies. KESIMPTA has powerful efficacy and has demonstrated superior reductions in annualized relapses of up to 58% versus Aubagio. There was also near complete suppression of gadolinium-enhancing T1 and T2 lesion activity as seen on MRI.
And this included patients who never took an RMS therapy before?
Absolutely. 40% of patients in the clinical trials were treatment naive. We know that the first treatment choice after diagnosis matters. In treatment-naive patients, KESIMPTA show a 50% relative reduction in ARR, even less than one relapse every 10 years, and more importantly, in my opinion, a 95% reduction in mean gadolinium-enhancing T1 lesion activity. This is the type of efficacy I expect for first-line RMS therapy.
I will never forget seeing my first MRI scan. I had so many lesions. All I could think was, can this get any worse?
I know that feeling. If I could go back in time, I would tell my past self that you're gonna be okay, but you need to be honest and speak up about what you need. Eventually, I had to be real with myself and reflect on what was important, reframe how my diagnosis was impacting my life, and focus on how I was feeling.
That's a great transition to the 6-year data. Here, we see that 9 out of 10 patients who started on KESIMPTA first line achieved what we call NIDA-3, or no evidence of disease activity. NIDA-3 is defined as 1, no 6-month confirmed disability progression, 2, no confirmed RMS relapse, and 3, no new or enlarging T2, and no GAD-positive T1 lesions. Bear in mind, these patients have been on KESIMPTA for a total of 6 years. We also saw a 30% risk reduction in the rate of 6-month confirmed disability progression after 6 years among patients taking KESIMPTA first line versus those who switched from Aubagio after taking it for up to 30 months.
I remember my doctor explaining this to me. I felt like we were really getting ahead of it and thinking of my future. Although, to Jamie's point before, I did have a concern at the time. If the treatment was high efficacy, did that mean it would make me feel sick after taking it, or would it give me any weird side effects?
The potential side effects of any therapy are incredibly important to consider and talk about. I make sure to discuss it at length with my patients, bearing in mind the important safety information I mentioned earlier. KESIMPTA has an established safety profile comparable to Aubagio in the pivotal trials and in the open-label long-term extension study. The overall rate of infections and serious infections in patients treated with KESIMPTA was similar to Aubagio. The tolerability profile is equally reassuring. The incidence of systemic injection-related reactions decreases with subsequent injection. By the 3rd dose, injection-related reactions occurred in fewer than 3% of patients.
That's reassuring to hear. And the Sensority pen itself is great from a convenience standpoint. I mean, don't get me started about self-administration. I love that I can take it on my own time.
Same. You can even keep the pen at room temperature for a week, which means I can take it on the go even when I have a volleyball game that's far away.
KESIMPTA is the first and only self-administered subcutaneous B-cell RMS treatment taken at home or on the go, which I imagine means a lot to you gals.
More time for friends and family.
And more time in my day for more baseball games with my boys.
Jamie, Caylee, great chatting with you. Thanks for joining. Please keep watching for the full important safety information and keep an eye out for more videos about KESIMPTA. You can always dive deeper into the data at KESIMPTAHCP.com.
Indication and important safety information. Indication. KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis, MS, to include clinically isolated syndrome, relapsing-remitting disease, and active secondary progressive disease in adults. Important safety information. Contraindications. KESIMPTA is contraindicated in patients with active hepatitis B virus, HBV, infection, or history of hypersensitivity to ofatumumab, or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reactions have included anaphylaxis and angioedema. Warnings and precautions. Infections. Serious, including life-threatening or fatal, bacterial, fungal, and new or reactivated viral infections have been observed during and following completion of treatment with anti-CD20 B-cell depleting therapies. The overall rate of infections and serious infections in KESIMPTA-treated patients was similar to teriflunomide-treated patients, 51.6% versus 52.7%, and 2.5% versus 1.8% respectively. The most common infections reported by KESIMPTA-treated patients in relapsing MS, RMS, trials included upper respiratory tract infection, 39%, and urinary tract infection, 10%. Delay KESIMPTA administration in patients with an active infection until resolved. Consider the potential increased immunosuppressive effects when initiating KESIMPTA after an immunosuppressive therapy, or initiating an immunosuppressive therapy after KESIMPTA. Hepatitis B virus. Reactivation. No reports of HBV reactivation in patients with MS treated with KESIMPTA. However, HBV reactivation, in some cases resulting in fulminant hepatitis, hepatic failure, and death, has occurred in patients treated with ofatumumab at higher intravenous doses for chronic lymphocytic leukemia, CLL, than the recommended dose in MS and in patients treated with other anti-CD20 antibodies. Infection. KESIMPTA is contraindicated in patients with active hepatitis B disease. Fatal infections caused by HBV in patients who have not been previously infected have occurred in patients treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. Perform HBV screening in all patients before initiation of KESIMPTA. Patients who are negative for HBsAg and positive for HB core antibody, HBcAb+, or are carriers of HBV, HBsAg+, should consult liver disease experts before starting and during KESIMPTA treatment. Progressive multifocal leukoencephalopathy. No cases of progressive multifocal leukoencephalopathy, PML, have been reported for KESIMPTA in RMS clinical studies. However, PML resulting in death has occurred in patients being treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. In addition, JC virus infection resulting in PML has also been observed in patients treated with other anti-CD20 antibodies and other MS therapies. If PML is suspected, withhold KESIMPTA and perform an appropriate diagnostic evaluation. If PML is confirmed, KESIMPTA should be discontinued. Vaccinations. Administer all immunizations according to immunization guidelines. For live or live attenuated vaccines, at least 4 weeks, and whenever possible, at least 2 weeks prior to starting KESIMPTA for inactivated vaccines. The safety of immunization with live or live attenuated vaccines following KESIMPTA therapy has not been studied. Vaccination with live or live attenuated vaccines is not recommended during treatment and after discontinuation until B-cell repletion. Vaccination of infants born to mothers treated with KESIMPTA during pregnancy. For infants whose mother was treated with KESIMPTA during pregnancy, assess B-cell counts prior to administration of live or live attenuated vaccines. If the B-cell count has not recovered in the infant, do not administer the vaccine, as having depleted B-cells may pose an increased risk in these infants. Injection-related reactions and hypersensitivity reactions. KESIMPTA can result in systemic injection-related reactions and hypersensitivity reactions, which may be serious or life-threatening. Injection-related reactions with systemic symptoms occurred most commonly within 24 hours of the first injection, but were also observed with later injections. There were no life-threatening injection reactions in RMS clinical studies. In the post-marketing setting, additional systemic injection-related reactions and hypersensitivity reactions have been reported, including anaphylaxis, angioedema, pruritus, rash, urticaria, erythema, bronchospasm, throat irritation, oropharyngeal pain, dyspnea, pharyngeal or laryngeal edema, flushing, hypotension, dizziness, nausea, and tachycardia. Most cases were not serious and occurred with the first injection. Symptoms of systemic injection-related reactions may be clinically indistinguishable from acute hypersensitivity reactions. The first injection of KESIMPTA should be performed under the guidance of an appropriately trained healthcare professional. If systemic injection-related reactions occur, initiate appropriate therapy. Patients who experience symptoms of systemic injection-related reactions or hypersensitivity reactions with KESIMPTA should be instructed to seek immediate medical attention. If local injection-related reactions occur, symptomatic treatment is recommended. Reduction in immunoglobulins. As expected with any B-cell depleting therapy, decreased immunoglobulin levels were observed. Monitor the levels of quantitative serum immunoglobulins during treatment, especially in patients with opportunistic or recurrent infections and after discontinuation of therapy until B-cell repletion. Consider discontinuing KESIMPTA therapy if a patient with low immunoglobulins develops a serious opportunistic infection or recurrent infections, or if prolonged hypogammaglobulinemia requires treatment with intravenous immunoglobulins. Liver injury. Clinically significant liver injury, without findings of viral hepatitis, has been reported in the post-marketing setting. Signs of liver injury have occurred weeks to months after administration. Patients treated with KESIMPTA found to have an alanine aminotransferase or aspartate aminotransferase greater than 3 times the upper limit of normal, ULN, with serum total bilirubin greater than 2 times the ULN, are potentially at risk for severe drug-induced liver injury. Obtain liver function tests prior to initiating treatment. Monitor for signs and symptoms of hepatic injury during treatment, including new or worsening fatigue, anorexia, nausea, vomiting, right upper abdominal discomfort, dark urine, or jaundice. If symptoms of liver injury are reported, measure serum aminotransferases, alkaline phosphatase, and bilirubin levels. Discontinue KESIMPTA if liver injury is present and an alternative etiology is not identified. Fetal risk. Based on animal data, KESIMPTA can cause fetal harm due to B-cell lymphopenia and reduce antibody response in offspring exposed to KESIMPTA in utero. Transient peripheral B-cell depletion and lymphocytopenia have been reported in infants born to mothers exposed to other anti-CD20 B-cell depleting antibodies during pregnancy. Advise females of reproductive potential to use effective contraception while receiving KESIMPTA and for at least 6 months after the last dose. Most common adverse reactions. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions.